Hello, everybody. Thanks for joining us today. My name is Shea, Gilliam, and I'm an emergency physician and EMS physician at Denver Health Hospital. And today we'll be discussing an introduction to chest tube placement and management in the disaster setting. So these are the mandatory disclosures for all of these just-in-time training videos. So you can take a look at those. And then I don't have any other conflicts of interest or other financial disclosures to discuss today. So can't have a lecture without discussing kind of what we're going to cover today. So here's kind of our roadmap for what we're going to discuss. Obviously, this is a 20-minute or so overview of placing chest tubes. It obviously is not going to replace, formal education or training in this, but it should serve as a quick overview of, if it's been a little bit since you placed a chest tube, kind of the do's and don'ts and the quick down and dirty, how to get there, especially in a disaster setting when it may be something that you haven't done in a long time. So we're going to kind of go over the brief anatomy and definitions. So we're all talking on this, using the same language. We'll talk about making the diagnosis, placing the tube, and then a few other considerations. So the anatomy. So as a reminder, the parietal pleura is that lining over the outside of the chest wall. And then there's a second lining called the visceral pleura that lines the covering of the lungs. Those two pleuras create this potential space. This pleural space has a very thin fluid-filled space between those two layers. That's where our air and our blood collects during a pneumothorax, which would obviously be air, and then blood collecting in that space would be a hemothorax. Obviously, you can have a little bit of both, so a hemopneumothorax. Really, anything can collect in that potential space. Today, we're primarily talking about in the traumatic indications for chest tube placements. We're going to be talking primarily about air and blood. And remember that the way the lungs work is a negative pressure system. And so as our diaphragm contracts and it creates negative pressure, these two pleural spaces in that potential, or those two pleuras in that potential space keeps that negative pressure and allows the lungs to work the way they're supposed to. So going through what we define, the different types of injuries that can occur. So we talk about a spontaneous pneumothorax. We see this a lot in kind of young, tall, thin people, males predominantly. They can get just spontaneous pneumothorax. We also see it in our COPD and emphysema patients where they get a rupture of a bleb, really no trauma. Sometimes with the history, there might have been a small incident that occurred, but typically this is not your classic, auto pedestrian accident or blunt trauma to the chest. These are considered spontaneous. Traumatic closed pneumothorax, obviously there's trauma. Closed meaning that there's no hole with the outside world. So typically a blunt injury, there's no penetration into the chest wall. Typically what causes these pneumothoraces is a rib fracture as it cuts through that pleura, or you can rupture a bleb from a traumatic reason. The other more common thing that we see, especially in the penetrating trauma world, is an open pneumothorax. This could be from a ballistic missile, like a gunshot wound, from shrapnel, from a knife, really anything that penetrates into the chest wall. That creates a loss of the negative pressure, and the respiratory mechanics obviously are going to change. And one complication of this is what we talk about a lot, and is a harder diagnosis to make than you really realize, is a tension pneumothorax. That's what this picture here is showing. It's basically a one-way valve of air in, but air can't get out. So every time you take a breath, air takes the path of least resistance, comes in that hole through the chest wall, and starts filling that potential space, and ultimately can lead to lung collapse, mediastinal shift. And the reason we get low blood pressure, hypotension, and cardiac arrest is we decrease our cardiac filling and ultimately our cardiac output. As it pushes on the right ventricle, that's the weaker of the two ventricles, and so the blood can't fill correctly, and you can't pump your blood the way you need to, and your blood pressure tanks, and ultimately this can be the cause of death for somebody with a penetrating open pneumothorax. Hemothorax is blood in the pleural space, so this can be from any number of reasons. One of the more common things we see is these intercostal arteries bleed significantly if they're lacerated. The heart, great vessels, the lung vessels themselves can also cause bleeding into the lung space or into that pleural space. Arterial injuries typically are going to require a surgical intervention, are not going to stop with just your typical, there's not an easy way to do direct pressure, and as you evacuate that space, the blood is just going to continue to pour out. So we talked about pneumothorax, both spontaneous and traumatic, as well as hemothorax. So how do we make the diagnosis? So we talk a lot about symptoms in medicine, and this is one of those that's really challenging, especially if you don't have a good story for a pneumothorax. The obvious penetrating trauma is a little bit easier to consider, but there's mental roadblocks when it's less traumatic, less obvious. So our symptoms can really vary. They can, be anywhere from just a little bit of dyspnea and a little bit of pleuritic pain, pain when you take a big deep breath, little bit of shoulder pain, a mild cough, and obviously in our respiratory season, we can get kind of missed on this, all the way up to severe dyspnea, hypotension, cardiac arrest. So the range of symptoms is quite significant. The exam is obviously what's taught is that you'll hear unilateral decreased breath sounds. Honestly, that's pretty challenging to hear, especially depending on your environment. And in a disaster setting, it might be working in an austere or loud or difficult environment than what you might be used to. You also might see tachypnea, tachycardia, subcutaneous emphysema. That's that kind of Rice Krispie feeling on the skin when you palpate their chest wall or their neck. That crepitus or subcutaneous emphysema should be a huge flag that there's potentially pneumothorax or at least air getting somewhere where it shouldn't. So in the stable patient, the symptoms and exam are overall less helpful and maybe very subtle. So a pneumothorax less than 20% of the hemithorax, so that half of the chest, you can still have completely normal lung sounds. So despite the fact that they have a pretty significant pneumothorax, you will probably still hear normal breath sounds, which makes this challenging. Pleural fluid collections, whether that's blood or another fluid, it takes about 500 milliliters, so half a liter, to really detect that on exam. So you can have pretty significant bleeding into the chest, and you may not be able to detect it clinically. In the unstable patient, pneumothorax should be considered really kind of first initially in that primary survey. In your A for airway, B for breathing, C for circulation, D for disability. The pneumothorax should be considered in that unstable trauma patient. Tachycardic, hypotensive, dyspneic, really that should be a high consideration, and potentially doing needle decompression, which we'll talk about later kind of empirically in those significantly sick patients. So obviously there are mimics, just like everything else in medicine. So as you obviously recognize, PE, cardiac tamponade, a significant pneumonia could also have very similar symptoms. You may see JBD and tracheal deviation are talked about quite significantly, especially attention pneumothorax. Those are typically late findings. So obviously if you see them, it's a bad sign. But if you're waiting to see those signs, it's going to be too late before you detect that. So how do we make the diagnosis? We talked about the clinical side of the symptoms that you should at least be considering and evaluating for. And then obviously we need to talk about some of the imaging modalities that might be available to us. So ultrasound has become pretty widely available in most departments now. And you should have had some training at some point on ultrasound. If you haven't, I suggest that it's a pretty unique, very helpful tool that has a lot of versatility, especially in a disaster setting where other resources might be limited. There's pocket ultrasounds now. And so we're not going to go through an entire ultrasound lecture today, but these are some representative images of what you may see. So the image on the left side here shows what's called the seashore sign. So this is in M mode. This is the lung, the chest wall here in M mode. That's what this bar is. And so you can see the sand and the waves here is what they call the seashore. So this big clear differentiation where you have the skin and the pleura. So they look different. And this is a normal lung, no pneumothorax. On the other side here, it's commonly called the barcode sign, where you lose that differentiation, right? All the lines look the same. It looks like a barcode you might scan, in your self-checkout or whatever. That's what you're seeing here, and that's a sign that there's a pneumothorax there. And so ultrasound is one of the main ways we're going to diagnose this. It's better than chest X-ray ultimately for these smaller, more subtle pneumothoraces. And obviously, chest X-ray is the standard that we've all been trained on. You can see here on this chest X-ray, the arrow sign is always helpful. You can see the lung here is obviously deflated. There's mediastinal shift. There's tracheal deviation. This is a pretty large tension pneumothorax likely. And so X-ray, ultrasound are your biggest ways to truly make the diagnosis. And obviously, during a disaster, your resources may be limited. You may be waiting. So trying to come up with different ways to make the diagnosis is going to be helpful in that environment. So we've talked about some of the definitions. We've talked about the anatomy. Let's talk about the overview of how to place a tube. Again, this is not going to replace your formal training, but it should hit the high points, help you understand the details you need to know in the minute if you need to place a chest tube. So talk about kind of the 5 key areas that I think about when I'm placing a chest tube. Site selection, so figuring out where we're going to place it, which site has the pneumothorax, and where in the chest. Patient prep, so getting set up is obviously the most important thing of any procedure, is having all your equipment, everything ready right at the beginning. The actual nuts and bolts of placing the tube, securing the tube, and then talking a little bit about the different drainage systems that exist. So, site selection. On the chest wall, where the sternomanubrial joint, that little notch on your chest, that is where the second rib attaches. So just below that, A here, which is the second intercostal space, that's where we do our needle decompression, which we'll talk about a little bit later. B over here is the 5th intercostal space. So the 4th or 5th intercostal space, are the typical areas where we're placing a chest tube. And those can either be in the anterior axillary line, so a little bit more anterior like here, or the mid axillary line. That's right in the middle, kind of imagine a line from the armpit down. Both of those are appropriate. So you kind of have 4 spots to go, anterior or mid, 4th or 5th intercostal spaces. The reason we go so high is that the diaphragm actually goes significantly higher in the chest than we all believe. We all think of it as being pretty low in the abdomen, but the diaphragm and the abdominal contents are actually quite high into the chest wall. And so when in doubt, go a little bit higher to avoid hitting some of those intra-abdominal organs. So we've made our site selection. Now it's time to prep the patient. Prepping the patient, the most important thing, honestly, is to prep your equipment. Most departments are going to have a chest tube tray or a chest tube kit or your kind of predetermined disaster supply kit. These are kind of the overview of things that you would want to make sure you have. Most importantly is you need a scalpel and you need some Kelly clamps. And other than that, you can kind of make it work with what you have. Obviously, I'm not going to read this list to you, but you need a ton of equipment to make this done sterilely and appropriately so you can have the best safety for you and for the patient. Don't forget about your drainage system so you have something to plug it into, and having your nursing or other department staff available to help you with this. This is not a single person job. This is a team job. You need at least one other person to help connect everything and have that second set of hands. So chest tube sizes, obviously there's a lot of debate and discussion in the literature now. There's been a general trend towards using smaller size chest tubes. 42 French, that's a huge chest tube. That is a garden hose. And the morbidity from that, the side effects and the long-term recovery and some of the complications from that, we're really trending more towards the smaller chest tubes. There's no formal guidance that I have for you today as far as which tube is the right tube. Kind of depends on your department's practice as well as what's available to you. Obviously, in a disaster setting, chest tubes might become a little bit harder to come by. You might be stuck with what you have. So keeping in mind that smaller generally can do the same as a bigger chest tube. We used to be taught that 36 French was the minimum for anything with a hemothorax. Now we're doing more like 28 is more reasonable. But again, kind of defer to your department's standard practice, but smaller seems to be working more than we initially thought. And then pediatric size, obviously go based on your pediatric tool that you use, that you're hopefully using at your department. There are a number of different age-based and size-based guides out there that will help you pick the chest tube that's correct for the patient's size. So prepping the patient, in a perfect world, our patients are going to be at a little bit of an incline, 30 to 60 degrees. The main reason for that is it's going to theoretically help bring some of those abdominal organs down low and get them out of your way. A lot of times in our trauma patients, obviously that's not going to be possible. Again, we want to have that ipsilateral or same side arm up and out of the way. If they're awake, they can sometimes hold it up, but that's a long time to hold it. You can use a soft restraint or tape or have an assistant help you hold that arm out of the way just so they don't contaminate your sterile field. Having them on the monitor, having them on oxygen, kind of our standard treatment for a pneumothorax. If you've never had one of these placed or you haven't placed one in a long time, they are extremely painful. We're cutting through a lot of tissue. There's a lot of nerve endings in there. These are very, very painful in your awake patient. Obviously, in your cardiac arrest, that's a very different circumstance. But assume that they're going to feel it, even if they're a little bit confused. Using a lot of local anesthesia is going to be really key for this. And if you have a fully awake patient, maybe this is an older person with a bleb that ruptured that's fully awake and talking, you can consider giving them parenteral or IV, IM, or intranasal analgesia. So pain medicine or anxiolysis, a little bit of Versed or Valium, whatever you use to kind of take the edge off. You can do procedural sedation if you need to. Obviously, this patient population in the trauma setting or in a disaster setting where resources are going to be limited, that's going to be a little bit of a challenge because most facilities require significant rules and boxes to go through before you can do a full procedural sedation. So having a couple other tools in your toolkit to at least take the edge off of some anxiolysis or give them some pain medicine to really make this procedure the best chance for success for both them and for you. Remember, when we're doing our local anesthesia, we want to do kind of outside in. So we're doing the skin, we're doing the superior rib area. Remember, we're going up and over the rib. We'll talk about that. You want to go through the muscle, hit the periosteum, and you want to actually go all the way to the parietal pleura. Aspirate as you go. You'll probably get that rush of air or blood as you enter into that pleural space. But you want to numb up the entire tract that you're going to be placing that chest tube. It's not so much the scalpel when you make the first cut, but it's the blunt dissection. It's the kind of tearing of the muscle that can be really, really painful. So we've talked about site selection, prepping our patient. We have all of our equipment. We have our team, whoever might be available in that disaster setting, at least one other person ideally. But now it's time to actually place the tube. So we'll kind of do what we always do, prep and drape the chest, right? So we're cleaning, we're putting our sterile drapes, we're trying to make the area as clean as possible. We're assuming this isn't like a code, or a cardiac arrest chest tube where we're kind of getting in quickly. We want to use anesthesia, local anesthesia, pain control, anxiolysis, or procedural sedation. We want to make sure we have our equipment, right? So we're ready. We have our number 10 blade. We're going to make a 3 to 5 centimeter incision in the area that you've selected, either the 4th or 5th intercostal space, anterior or mid-axillary line. So 3 to 5 centimeter incision. We don't want to go too big. That's more stitches and more morbidity for your patient. Remember, we're going up over the rib. This picture does a nice job of showing kind of you're looking end on at the ribs. You can see that the vessels run underneath the ribs. So we're going up and over the ribs to try and not hit any of the vessels, obviously causing more injury, more bleeding than would be necessary for the chest tube. So you're gonna make an incision above the rib, just above the rib, just to get through the skin and a little bit of the muscle there. And then we're gonna bluntly dissect. That's what these curved Kelly clamps are for. You're keeping them closed, you're going up and over the rib, and you're kind of using those to blunt dissect through the soft tissue over the rib to get into that pleural space. So once you're kind of dissected through that soft tissue, it's a pretty significant pop. That pleura, that parietal pleura, is quite thick, and it is a very definitive pop once you get through. Once you get through, if this is a hemothorax, you're going to start getting blood, excuse me, blood coming out. And so once you pop through, then we're going to open up our Kelly clamps and spread that space a little bit. This is where that tearing occurs and can be pretty painful if you haven't numbed up that parietal pleura. So you're going to spread that big enough that you can get a chest tube and your finger into that space. Again, we don't want to make it too big. Now we're going to have an air leak if we make this spreading too big. But you want to be able to make it big enough that you can put your finger in there and a chest tube right next to it. So once you've spread that, before you take the Kelly clamps out, you're going to put your finger in next to your clamps. Put your finger all the way in. You want to be able to feel the lung. And importantly, you want to make sure that you're not feeling any abdominal organs, right? Like the spleen or the liver. Sometimes those have a habit of breaking through the diaphragm, especially in a blunt trauma. So you want to make sure that you're not feeling a bunch of abdominal organs, or maybe you went too low before you put a chest tube into the spleen. We want to make sure we're in the correct space. You've got your finger in there. And the other important reason we're doing that is to keep that tracked, especially if the patient has a lot of adipose or additional soft tissue. That tract can get lost pretty quickly. So you really want to leave something all the way into the pleural space the whole time. So it's never left alone. You have your finger in there. And then the thing you're going to do is place the chest tube into the chest. And so you can do that one of two ways. You can either hold the chest tube by itself and place it next to your finger. I like to use the Kelly clamp to kind of clamp the end of the tube. It allows you to drive that chest tube a little bit more deliberately where you want it to go. So I usually feed the Kelly clamp through one of the holes at the end of the chest tube and clamp the end of the tube. And it allows me to drive that chest tube into the chest wall where you want it to go. Now, remember, we're angling to try and get the chest tube all the way to the apex of the lung, so towards the head. So really, we're aiming kind of medially, so we're going in. We're going to aim posterior, so we're laying along the back of the chest wall, and we're going to aim towards the apex of the chest, or apex of the lung, so all the way to the top. This should go in pretty easily. If you're getting a lot of resistance, it means that you're probably somewhere where you shouldn't be. It's either subcutaneous, we didn't get all the way in, or you've hit a fissure of the lung, or you're all the way to the mediastinum. So if you're using a lot of force, use that as a red flag, pull back, reassess your location, see if you need to angle your chest tube more posteriorly is typically what will help, and more superiorly, so you're aiming towards the head. You can estimate the size or how deep you need the chest tube to go before you put it in, by kind of looking at the clavicle to the spot that your chest tube is going to go in. That's roughly the distance that you're going to go in. The important thing is you want to make sure all the drainage holes are inside the thorax before you consider your chest tube all the way in, because if one of those two holes is out, you're going to get air from the atmosphere that's going to complicate your chest tube's function, and it's really not going to be useful. So you've got your chest tube in place. You've got your drainage system that you set up ahead of time ready, and you're going to connect that right then so you can start evacuating that air and that blood. And we're going to talk about that separately as well. So the next thing is securing the tube. Obviously, we don't want all our hard work to go to waste. And so the best thing to do is to stitch this into place. Again, you've used a lot of local anesthesia. You've numbed up that entire area. So you want to make sure that when you were doing that, you've numbed up enough space that you can actually stitch without having to numb again. So you're using a pretty large stitch, a 0 or a 1/0 silk or nylon suture. Typically, you're using that with a hemostat, not a straight needle. It's a little bit easier if you have a hemostat. Either one works. We're going to go through kind of two techniques here. The overall theme here is that you want to stitch the skin and you want to tie the tube to the skin, essentially. So this first idea, this first option, is that you've made a regular stitch at the top of the tube. Regular stitch, just like you would if someone had a laceration. But you're going to leave your tails long and you're going to wrap it around the tube tightly, tie a knot, and it's going to hold the tube in place. If you were a little generous with your incision, you can also kind of stitch up the skin a little bit. It's going to help seal your chest tube, help it work a little bit better. You want that nylon or that silk tight enough around the tube that it's not cutting off the tube, obviously, but you want it indenting the tube a little bit so that when you give it a little pull test, it's not going to pull right out. The other option, which I'm more of a fan of, is this horizontal mattress. You can still do that initial suture at the top to kind of close that dead space. This horizontal mattress suture actually goes around the chest tube. As you can see in this picture, you kind of enter on the right, you go above the chest tube, and then you enter below the chest tube. And so you're making this it kind of holds the tube in place there. And it also is going to be used as the stitch that closes the skin when they pull the chest tube out. So it kind of has two functions. So this one, you're not actually tying it down to the skin. It's just a simple knot. It's not locked. It's not a full suture. And then you're going to wrap the tails like you would on the other suture. And then you're going to tie that. Same idea. You want the tube indented, but not collapsed all the way. So those are the two main ways. There's a ton of different ways to stitch these in place, but those are the two principles. The idea overall is you want to make sure that this isn't going to pull out. Tape alone is not good enough. Stitching it in place is the gold standard. Once it's stitched into place, then we do want to put in a petroleum impregnated gauze or a Zeroform type gauze, something between the chest tube and the chest wall that's going to help seal that. So there's less air and liquid escaping there, helps keep that system closed. So you're going to use that kind of impregnated gauze or petroleum-based gauze first along the chest wall. You can make a little cut through that, little Y-shaped cut that go around the tube. You can do gauze on top of that, and then you're going to tape it. The other thing that I really like to do is this anchor tape. It's another stopgap to help prevent your tube from getting pulled out in that disaster setting where you might be placing this somewhere you normally wouldn't, and these patients are potentially going to get moved more often than they otherwise would. This is going to be really important to help reduce the risk of that tube getting pulled out. Obviously, we'd like to get a chest x-ray as soon as you can to confirm that the chest tube did not get stuck in the fissure or go directly into the lung or is somewhere where it shouldn't be. If you can do that while you're still sterile, that's ideal because you can still advance the tube if everything is still sterile. If you've broken sterility and you're waiting, you've taken everything down, you're getting the chest x-ray, and you need to advance the tube, you really can't. At that point, you'd have to place a second tube. Rarely are you going to pull back. A lot of times you're kind of advancing or redirecting the tube. So you want to get an x-ray. That's your gold standard to confirm that the tube's in the right place. You obviously know you're in a decent place. If you got a rush of air, you're getting a bunch of blood out, but the chest x-ray is going to be key to confirming that. And then what drainage systems are we going to use? There's a ton of them out there. We're not going to go into too much detail about the exact intricacies of running these because every one of them is just a little bit different, but the features or kind of the key concepts are the same. The idea is that there's a one-way valve. So it's allowing air or liquid out and allowing nothing else to go back in. And then the suction mechanism from the wall or a portable suction machine in a disaster setting is going to help increase that rate of drainage. So the options, we sometimes will do this, if you're placing a pigtail catheter for a spontaneous pneumo, a flutter valve or Heimlich valve, maybe all you need. There's no blood, there's no liquid, and that flutter valve, they can actually go home with in some cases, depending on your institution's practice. And then an underwater seal is the gold standard now. That's what this one over here, this is an example, is an atrium. The depth of the water that's on that left side here, that blue side, really determines the amount of suction that's happening. And so the wall suction is set, but it's really that volume of water and how tall that water is that's going to affect your suction and how that's draining. And so the whole idea there is a different way, a more complicated but more nuanced way of draining the chest wall and not allowing anything to go back into the chest. So we talked about kind of the standard tube thoracostomy chest tube. We're going to talk about a few other things here that we should be aware of and other options that we can consider in our patients that might need a chest tube. So needle decompression, we talked about this a little bit. This is for that really truly life-saving intervention in a disaster setting. This may be your only option. You may not have a chest tube available to you. These are for our patients that we're concerned have tension pneumothorax, right? So apnea, hypotension, they have a blunt or penetrating cardiac arrest. potentially doing a needle decompression bilaterally might be reasonable in that setting. And remember, we talked about the second intercostal space is the typical place we do that in the anterior or in the midclavicular line. That's kind of the classic teaching for a needle decompression. There was a study a little while ago that showed that a lot of those needles don't actually make it into the pleural space due to adipose, or if you have a young, 22-year-old Marine that's been, has a significant amount of pectoralis muscle, you may not reach the chest wall. If you do, you should see a rapid improvement in their vital signs because you're getting that air out. This does not replace the need for a chest tube. This just buys you time to get your equipment in place. What about a finger thoracostomy? There's been a lot of discussion about needle decompression not really working that well, having mixed benefit. And so there's been a push in some ways to do a finger thoracostomy, which is basically the beginning steps of a chest tube with the goal of venting the chest. So we'll do this often in the emergency department with a blunt cardiac arrest or a penetrating trauma arrest, where we'll vent the chest because we want to make sure that we are able to get all that blood and air out and obviate or fix that tension physiology. And so basically you're doing the same thing. You're cutting, you're using your clamps to bluntly dissect, you're opening that pleural space to the environment. The argument here is that once you've done that, then you just need to place a chest tube. You're already kind of halfway there. So this can be a little bit quicker sometimes, especially trying to find a 14 gauge needle in the heat of the moment. Most people have a scalpel nearby. Sometimes that's really all you need. And then we'd be remiss to not talk a little bit about the pigtail catheter. These are definitely used more often than they were when I first started my training. This has definitely become more of a reasonable option, especially in the spontaneous pneumo, and really even in some of the smaller hemothorax. I've seen this a couple of times. There is definitely some data that a pigtail catheter could be used. It kind of depends on the patient and your surgeons and your institution's practice. But a pigtail catheter is obviously a lot less morbidity for your patient. It's a lot less pain. It's a classic technique that we're used to. It's typically a Seldinger technique, needle, wire, tube. And so each kit is very different. Some have a trocar, some have this very, classic Seldinger technique. It really depends on the kits that you have. So my encouragement to you would be to become familiar with what your department stocks. Every emergency department hospital stocks different things, and your disaster kits might be even more different than what's part of your frontline equipment. So becoming familiar with what they have, but recognizing this may be the only thing you have to treat their pneumo or hemothorax initially. It kind of depends on what the patient's needs are, but these do exist and are reasonable in some cases. So that was a crash course. We talked about the anatomy. We talked about the different definitions of pneumothorax and hemothorax, making the diagnosis, how to place that tube. We talked about some of the alternatives like needle thoracostomy, finger thoracostomy, and that's it. So thank you very much for your attention. I hope this was helpful. And if you have any feedback or other thoughts, please don't hesitate to reach out to us. Have a great day.